So we're going to be talking about surgeons and how we think about melanoma and what we do with it. And this is going to be focused mainly on patients with early melanoma, stages 0, 1, and 2. So we're going to be talking about surgery for the primary site. That's a big part of what we do. Regional nodal surgery has been a part of surgical melanoma care for a very long time. The way we practice that has changed. Surgeons will also be involved in melanoma care for resection of distant disease. I'm not really talking about that too much in this case, but it does come up from time to time. So melanoma has always been a surgical disease, and there was a time in history when that was really the only thing that medicine had to offer. If someone had melanoma, it would be surgically removed. There was a time during the last century when everybody had a big lymph node dissection of the regional node basin. And while melanoma is still partly a surgical disease today, we fortunately have a lot of other ways to treat melanoma. So over the past decades, the main changes are that we use smaller resection margins than were used a long time ago, which is great. And we have, in general, less lymph node surgery. There's still a lot of lymph node surgery involved, and we'll talk about that. But I do think we're going to see ongoing changes with newer insights into cancer biology and staging, and with new medical therapy. Surgical changes need to happen along with that. So when we take care of melanoma patients, the primary site is mainly for local control, that is getting rid of everything so that it doesn't come back at or near that area in the future. And operations on the regional node basin are partly for staging information, and that's for the last few decades, that's been mainly the Sentinel node biopsy, and also for regional control for patients who have disease in the regional nodes. There are some patients who might require a lymph node dissection for regional control. Not everybody today. So we'll talk about pathology. So once somebody has been to the dermatologist and they've had their biopsy, when I see a patient, they usually come with a pathology report, and there's a lot on that report, and that what's on there has changed over the years. So at the top of this list, I put the 3 most important things. So the single most important thing here is the thickness in millimeters. It's also called the Breslow thickness. It's measured with a little ocular micrometer. Second most important thing is histologic ulceration, which means loss of the outer surface over the top of the melanoma. Ulceration is a poor prognostic factor, and it is part of the current staging system, so that is always on the report. The third thing that we pay most attention to is the mitotic rate. Today it's reported as the number of figures per millimeter squared, also measured under the microscope. Those 3 things are the 3 things that we use the most for most patient presentations. The others are important, and they may take on certain importance in particular patients. I'll mention just in passing Clark's level. Many people have heard of the Clark's levels. They're no longer routinely reported, although you will occasionally see them on a pathology report. That was a system of describing what layer of the dermis was invaded by the melanoma. And with memory of Wally Clark, we no longer report that, but we remember it. The histologic type, as Dr. Gerstenblith was talking about, is important to us. Other features like regression, lymphovascular invasion, satellites, perineural invasion, also important. But it's really, for the average patient, it's the top 3 things that we're really paying attention to. So for every cancer, there is a staging system. And I think every staging system that I've ever worked with has been flawed. And that is true for the melanoma staging system as well. So the primary tumor is the T stage. And there's a lot on here, but the main thing to notice is that it is divided mainly by thickness. So if the tumor is confined to the epidermis, or the outer layer, it is a melanoma in situ, or a stage 0 melanoma. If it is 1 millimeter or less in thickness, it is in the T1 group. And now we'll see that the T1 through 4 are subdivided by whether or not there is ulceration. Ulceration bumps people up in severity. The T2s are between 1 and 2 millimeters, T3s 2 to 4 millimeters, and T4s above 4 millimeters. Regional nodes, well, here's where it starts getting kind of messy. So the regional node system is a bit complicated. The main thing to know here is that the sense of severity in terms of the regional nodes has to do with how many lymph nodes are involved and what the volume of disease is. Those are the main ideas for how we think about how does the node status contribute to our understanding of severity of disease. You'll notice over towards the right, it mentions the presence of in-transit satellites and or microsatellite metastases. I'll talk about those in a moment. Those are findings that are high-risk findings with a similar prognostic implication to having a positive node. What are they? So they are defined this way. So we know that melanoma often spreads through the lymphatic system. And if there are little tumor deposits that are separate from the primary tumor, but within 2 centimeters, those are satellite lesions. If they're appreciated only microscopically, they are microsatellites. Tumor deposits in the soft tissue that live more than 2 centimeters away from the primary tumor, but before the regional node basin, are called in-transit lesions. So those are additionally high-risk findings and often have a prognostic implication similar to having positive nodes. So pathologic stage groupings. So the easiest part of this is the top part. Stage 1 and 2 has to do with how thick the tumor is and the fact that the nodes are negative. Things start getting complicated once we get into stage 3. There's a lot of different ways that patients can end up being stage 3, and I think that is the part of the staging system that requires a lot of revision. So this was the way that the stage 3 melanoma patients were presented from the most recent published staging system. And you can see that the committee left themselves a lot of room for improvement. So you can see on the left side here that the stage 3 patients have now been divided into 4 different groups of widely varying prognoses. And in fact, if you look at the top 2 lines, the stage 3A and 3Bs, some of those patients actually have a better prognosis than some patients with stage 2 disease. And if you look at the right side of this page, it's a very confusing jumble of which box people fit into. I think this needs to be revised, and we probably really need some molecular findings and biologic findings to help us really better understand what someone's prognosis is. But to simplify things, at diagnosis, most people have early stage disease. So for invasive melanomas, 80 or 85% of them have stage 1 or 2 disease, meaning they have a primary invasive tumor, but no known regional or distant disease. About 10 or 12% have stage 3 disease, which means regional metastases, but no distant disease, and a very small percent will actually present with distant disease. So at the time we see somebody with a new diagnosis of primary melanoma, there are a number of things in our minds when we're thinking about what we should do or what we should recommend. So one is, are imaging studies or other testing needed? And how much tissue should be excised at the primary site? How big is the wide excision supposed to be? And what are we doing with the regional nodes? Do we need to do anything with the regional nodes at all? And for what purpose? Sometimes we operate on the regional nodes for staging, that is to get prognostic information, or for treatment to control disease at that site. So first of all, who needs baseline imaging? So for these patients presenting with a primary melanoma, stages 0, 1, and 2, most of them do not need baseline imaging. The chance that we would find any actual disease on cross-sectional imaging of the body at that point is extremely low. However, imaging can and should be considered for patients if there are concerning symptoms or clinical findings, like if we examine somebody and find a suspicious feeling lymph node, that's a reason to do some more imaging. Or if somebody presents with a very high-risk primary tumor, like a thick tumor with ulceration, if we think that that's going to be valuable for decision-making for that patient. If a patient presents to us with stage 3 disease, I think all of those folks really should have baseline cross-sectional imaging. Most of the time we don't find anything elsewhere, but I think it's important to have that at the very least as a baseline. So the wide excision. So every primary melanoma needs a wide local excision. And the purpose of that is for local control. That ages ago, every primary tumor used to be excised with a 5 centimeter margin, which led to a lot of skin grafts and in some patients, amputations. There were many, many clinical trials in the latter part of the last century and the aughts of this century that compared really big margins with lesser margins. And we now have it pretty well worked out about what margins give appropriate control for different thicknesses of melanoma. So the surgical margins that are recommended have not changed for the last couple of decades. They're pretty well ensconced. These are the currently recommended margins. There's a little bit of wiggle room in some of these. So for in situ melanoma, the standard surgical margin is 5 millimeters. Depending on the location and depending on some other factors, there are some circumstances where one might consider a bigger margin. For patients with thin melanomas, a 1 centimeter margin is definitely enough. There's no reason to do a bigger margin than that. For patients with melanomas that are 2 millimeters or thicker, a 2 centimeter margin is adequate, and there is no reason to do anything larger than that. The only group where there's some ambiguity is the group of patients who have a thickness between 1 and 2 millimeters. The current recommendation is 1 to 2 centimeters. I think it's likely that most of those folks would be fine with a 1 centimeter margin. There's an ongoing multi-center trial to try to better understand that or define that. So the lymph nodes. We've spent a lot of time talking about lymph nodes. So these are little structures throughout the body, and the lymphatic system is a circulatory system throughout the body, and we should think about the lymph nodes as functioning as like little filters within that system. So they will filter particles, and it's why lymph nodes may sometimes be enlarged in response to a nearby infection or injury. But they're often the first site of spread for many different kinds of cancer, including melanoma. So the sentinel node biopsy has been around for a long time now and is well established as a staging procedure or a prognostic procedure. And the basic idea is that lymphatic flow from the melanoma site will go preferentially through one or a limited number of lymphatic chains. They'll hit one or a small number of lymph nodes as the first site of spread before going on to other lymph nodes. And the sentinel node technique is just a way of finding those initial nodes and selectively removing them. And we know that if the sentinel node is negative, the others are very likely to be negative as well. So we've learned a lot about lymphatic mapping since starting doing the sentinel node. So way back in 1874, Sappi, who was a French anatomist, described the dermal lymphatic flow. He injected mercury into the skin of cadavers and then made these rather elaborate drawings of where the lymphatic circulation of the skin went. And it was all very orderly. That he described that it would seldom cross the midline, and he described a line around the center of someone's torso and called it Sappi's line. And we now know that it's not quite that simple. It's not uncommon to have lymphatic flow from one part of the torso cross the midline and go to the other side. We certainly have had lymphatic flow from the forearm go to the neck. There's a lot of unexpected findings when we do lymphatic mapping. So there have been many studies looking at the value of the sentinel node biopsy, and they are all pretty clear that the sentinel node status has prognostic significance. And for many patients with a newly diagnosed primary melanoma, it gives us the best prognostic information that we have. Some patients may end up being defined as having stage 3 disease if the sentinel node is positive. And the implication of that is that it may lead to the need for staging studies if they haven't had them already. It may lead to the consideration of systemic adjuvant therapy and a plan for closer ongoing follow-up. And this idea is supported by many different studies, which we're really not going into today. But one important thing to note is that the sentinel node use itself is not necessarily associated with better melanoma-specific survival. And that's important to remember in situations where we may be on the fence about whether a sentinel node is appropriate for a given patient. So we know that some features of a patient's presentation that are associated with having a positive sentinel node. Features of the primary tumor include thickness. By far, thickness is the most important feature. Ulceration is important. An elevated mitotic rate is associated with an increased chance of having a positive node, and the finding of lymphovascular invasion also associated with an increased chance. Anatomic location, head and neck primaries more likely to have positive nodes than truncal or extremity primaries, and age is associated with positive node, with younger people being more likely to have a positive node than an older person with the same tumor. And there are a lot of different statistical models that have been published to think about what's the chance that a person might have a positive node. I think they are all flawed in different ways. I don't use them routinely. One that we use occasionally is from the Melanoma Institute of Australia, and I think it occasionally gives relative guidance. I do not use this on a regular basis, but there are a variety of models out there, and in the future we might end up with better models. So given all this, who should be considered for a sentinel node biopsy? So we consider it for patients with invasive primary melanoma, particularly if they are clinically node negative, that is, we do not feel any enlarged or abnormal feeling nodes, and they either have a primary tumor thickness that's a millimeter or more. We will sometimes also consider it for patients with a thin melanoma, particularly if they're towards the high end of the thin range with certain high-risk features like ulceration or an elevated mitotic rate. But there are other considerations. That's not really the whole story. We have to take into account someone's comorbidities, that is, how their health is in general, their age, their life expectancy related to other health problems. We have to take into account the risk of anesthesia for that patient. Sentinel nodes in general will require general anesthesia, whereas some wide excisions could be done under local anesthesia. And for individual patients, that may lead to a change in the decision. And also a realistic patient expectation of benefit. Are we actually going to use the results? If we like when we do a test, we like to think we're going to use the results. And if this is a result we're not going to use, we should think long and hard about why we're doing it at all. So for patients who do have a sentinel node biopsy, they first go to nuclear medicine, and the folks in nuclear medicine do an intradermal injection of a tracer called technetium sulfur colloid. It is a tiny amount of a radioactive substance. There's the injection happening in nuclear medicine. They have a lymphoscintigraphy, which is just a way of getting a broad look at where that tracer goes. Usually we start to see the sentinel node within about 10 minutes after the injection. And then in the operating room, we use a little handheld probe called a gamma probe to help us hear where that tracer went. That technetium is a gamma emitter, and this probe turns that gamma emission into an audible signal so we can help find where that node or nodes are. This is a very old model that's not currently in use. Some surgeons will also use a visible dye. The most common one is isosulfan blue. I seldom use it for melanoma patients, but it is kind of pretty. That's what it looks like if you use the visible blue dye. So if the patient does have positive nodes, most node-positive patients have a microscopically positive node, either a few millimeters or even less than that, sometimes very small amounts, sometimes found only on the immunohistochemistry. And there's also a lot of discussion and a little bit of uncertainty about what size tumor deposit is really clinically meaningful. Is it 1 millimeter? Is it 0.3 millimeters? That becomes a decision that our medical oncologist would think about. So it used to be that we thought that if somebody had a positive node, we should go back and take out the rest of the nodes because we thought there was a good chance some of those other nodes might be positive. And from older studies, we used to think that there was about a 20% chance that there would be other nodes in that basin when we went back and did our dissection. So we now know that we really probably shouldn't be doing that in this day and age for most patients. So there were 2 large trials of node basin dissection, as was always done, versus careful surveillance. And they both showed the same thing, that immediate completion dissection did not improve melanoma-specific survival. It did somewhat improve regional disease control, and it provided, in some patients, some extra prognostic information if they did find additional positive nodes. But because it did not improve melanoma-specific survival, today we really should not be doing completion dissections for most patients. There may be exceptions to that, but there aren't very many of them. So we know that those patients, if they do have a relapse into that node basin, they may need a dissection in the future. And so the type of surveillance that we do, this mimics the type of surveillance that was done in those trials. For year 1 and 2, they get an ultrasound of that regional node basin every 4 months. Then in years 3 to 5, they get an ultrasound every 6 months. During that follow-up time, the chance of in-basin recurrence may vary with a lot of different factors about that patient, but overall it's about 10%. And so we do want to keep a close eye on that basin. Some of those patients may end up needing a lymph node dissection in the future. So I thought we'd end by looking at a few cases. These are fictional cases, and you can tell that because I've given them fictional names and I've totally made up their pathology. These are not real people. So first, we're going to talk about Miss Jane Eyre. So she is a 45-year-old woman, and she's been to her dermatologist and had a biopsy, and they found melanoma in situ of her left arm. This is a stage 0 melanoma. She certainly does not require any preoperative staging studies. Her best management is wide excision alone with a 5 millimeter measured margin. Once that is done, chance of recurrence of that should be 0 or incredibly close to 0. She will need to remain in skin screening indefinitely, as Dr. Gerstenblith told us. Next, we've met Miss Elizabeth Bennett, and she's a 22-year-old woman with an invasive melanoma at the right calf. So this melanoma pathology report says it is 1.2 millimeters in thickness. It is non-ulcerated with a mitotic rate of 2. So it's a T2 primary tumor. It has a slightly elevated mitotic rate. So we're a little bit concerned about this melanoma. It's not high enough risk for us to order any imaging evaluation. Primary site here should have a wide local excision with a 1 centimeter margin. Once that is done, her chance of local recurrence really should be 1% or less. It's not 0, but it's very low. And she also does qualify for a sentinel node biopsy, and that will help us understand whether she is at higher risk of future recurrence or lower risk of future recurrence. And I think it is an important part of her treatment, her management for a healthy young person with this finding. Next, we meet Mr. Twist. So poor Mr. Twist survived his terrible childhood, and he's now a 25-year-old with invasive melanoma at the right back. And this is a more challenging melanoma. This melanoma is 4.5 millimeters in thickness. It is ulcerated, has a mitotic rate of 10. So this is a pretty serious high-risk melanoma. And by that alone, he really should have some baseline imaging, and that could be either a CT scan or a PET CT, but he needs to have some form of baseline imaging. If we assume that that shows nothing, then his primary site should have a wide local excision with a 2 centimeter margin. I think that's appropriate to give him durable local control. He also would be a candidate for sentinel node biopsy, and with a melanoma of that description, his chance of having a positive node could be around 40 or 50%. So this is indeed a very serious problem. Regardless of the node status, it's important to note that this patient should have an oncology consultation regardless of his node status. Because even with a negative node, the primary tumor here has such high-risk features that he could be considered for adjuvant therapy, even if his nodes are negative. And we'll move on to one more patient, Mr. Sancho Panza. So he's now an 80-year-old man with an invasive melanoma at the left shoulder. So his pathology report says it's 1.2 millimeters, it's non-ulcerated, and it has a mitotic rate of 2. And if you've been paying attention, you'll notice this is exactly the same pathology report that Ms. Bennett had. But his situation is quite different. He's an older man. He's on home oxygen for his lung disease. He has congestive heart failure. He's a terrible candidate for anesthesia. He does not require any staging imaging for this presentation. And an appropriate management for him would be for a wide excision alone with a 1 centimeter margin. And we can do this under local anesthesia, so he doesn't need to undergo the risk of general anesthesia. I would recommend against a sentinel node biopsy for this patient. So those are all our fictional patients.